I'm Kurt Stange. I'm in the Department of Family Medicine and Sociology and Epidemiology and Biostatistics. And I'm happy to invite you to the first public forum for the FAB initiative. And we're delighted to have Laura Nasir here from both North Carolina and London, England. I'm going to introduce Laura in a minute, but I wanted to first tell you about the FAB initiative. FAB stands for Promoting Health Across Boundaries, and it's supported by a grant from the Forward Thinking Initiative of Case Western Reserve University. And these initiatives are trying to support cross-disciplinary, cross-school work that's going to advance the mission of the university. Peter Whitehouse has one of them for his work with the intergenerational school as well. The problem that the FAB initiative is trying to work on is the problem of fragmentation. And the problem that our view of health in the U.S. anyway often tends to be very narrowly focused on disease and health care. And that narrow focus on health care has often resulted in stealing resources from the other social and environmental determinants of health, and has resulted in unhealthy people, inequalities, and really a fragmented, unsustainable healthcare system. So with the FAB initiative, we're trying to look at what we do when we're crossing traditional boundaries, the boundaries of disciplines, of medicine and healthcare, of public health, of community efforts, of things that are not even particularly focused on healthcare, but that might actually have an effect on health. And we're trying to really look at the role of boundary spanning and boundary spanners in advancing health. And our speaker will actually define some of those terms for us a bit. Here's how we've kind of conceptualized this to begin with. The boundaries that we're particularly looking at in the FAB initiative are between the person and the family, primary health care, healthcare systems, and public health and community, and really focused on health. And so we've named those boundaries as personalized health care, healing environments, responsible, evolvable, or sustainable organizations, and then healthy environments. And so those are the boundaries that we're actually looking at in this initiative. I want to mention that we have a course that we're actually going to be teaching this summer. It'll be an intensive course done over 2 long weekends. So if you're interested in this, it's going to be a pretty interactive course. It's a graduate course that undergraduates can enroll in with permission. And this is a new field, and we're going to try to really work together between the students and the faculty to explore what's already known about boundary spanning, of disciplinarity, what's known about health and how health is lost and created. And we're going to try to work together by creating new knowledge. The course will actually result in the students having some skills in doing case studies. We'll have each student do a case study, and we'll do a cross-case analysis, looking at exemplars, people that are doing boundary spanning work that has an effect on health. So that's the background. I just want to briefly introduce Laura Nasir. Laura is an assistant professor at the University of North Carolina at the School of Nursing, but she's actually also spending several years now at the King's College of London. And I actually met Laura actually in London at a meeting. We have a common friend, Paul Thomas, and I was telling Paul that for me in my life right now, what's meaningful to me, what I'm doing that feels like it might make a difference is not the things that I'm doing by virtue of whatever title I have or my job or my discipline, or even particular projects or initiatives that I'm working on. The things that seem to me that I'm working on that have a chance to make a difference are using those things as platforms to do cross-cutting kind of work, to try to create space for dialogue, for people to work together on common problems, to look at our commonality. So as I was telling Paul about this, he says, you have to talk to Laura Nasir. And in fact, she's going to be at this King's Fund meeting where we are tonight, and we had great resonance about this. Laura is funded by a grant to study boundary spanning, and she's particularly looking at that as it relates to primary care and primary health care in a particular region of London. So I won't steal her thunder about that. She's going to give us a few definitions. She's going to tell us about some of her on-the-ground work, and hopefully we'll have time for some discussions at the end. Since we're just starting this initiative, we would just like to know who's kind of here and who might be interested. So if you would be willing to sign in on this, we would appreciate it. At the end, we'll have some munchies and some drink. We have a room next door that we've been told that we're not allowed to use. So at the edge of that room, we have the beer and wine and munchies. So you'll be able to get that and come back in here or go out in the hall afterwards. So without further ado, please help me welcome Laura Nasir.
Thank you. I'll have to start by saying I like to wander and talk a little bit, and I also like to know who you are. So I invite interruptions. So if there's something you want me to explain or you want to hear more about, that would be helpful for me. I am curious where some of you are coming from, what disciplines you might be representing, or what work you're doing. Just a quick kind of sense of nursing, medicine, dentistry, psychiatry.
I do different things, but I can declare nurse as one.
There you go. There you go. And we met in Amsterdam. Yep. Great. Sociology. Political science. History. Public health, bioethics. Medical humanities. Or so almost everybody's from a completely different discipline, which I think is really exciting. So I'm really glad to be here. My name is Calamos Nasir. I'm a nurse practitioner. I'm a faculty member and an academic, and I am a self-professed boundary spanner, which has finally come to terms with the fact that I don't like being held down too long. And part of that is because I see problems and I start to get really frustrated with them. When I was working in the hospital as a nurse, I worked in pediatric bone marrow transplant. I saw things happen every day that seemed like they could be fixed. That there was a system-wide problem, and it really frustrated me. But I had things I had to do. I had other things that I had to do. I moved on into family practice, where I felt like I could see people get better. We had a pretty high death rate on our unit when I was in the hospital at Duke, and I wanted to see people get well, and I wanted to see that I could make them well. And family practice was fantastic for that. But then again, it started happening. People kept falling through the cracks. I'd have one problem and it would happen again. Somebody who couldn't afford an inhaler, and I'd have to call the church to get the money, to get the inhaler, to solve somebody's asthma. And it seemed like it had nothing to do with primary care. And the system didn't seem to be making it better. It might even make it worse. So as much as I love seeing patients in primary care, academia was so comfortable. I could get to teach and I could work with students, and they were all excited about solving problems. But then they'd get frustrated with what real care felt like. And so academia wasn't quite satisfying. So I find that I'm happiest when I'm doing a little bit of everything. I want to teach. I want to do research. I want to see patients. But I want to see how all those places feed together. I am currently seeing patients in North Carolina in a rural health department when I see patients, but really right now, 90% of my time is in London. I'm embedded as a researcher in Northwest London watching primary care over 3 years, and that's what I'm going to be talking to you about from the boundary spanning point of view. What is a boundary? This is where a lot of the literature starts, right? It may feel a little bit simplistic, but the idea of a boundary is that there's something being separated, right? Some kind of line of demarcation, a line in the sand, separating me from you or in some other way. Maybe it's really fixed. Maybe my discipline doesn't speak the language your discipline speaks, and so we separate that, and sometimes it goes on and seems like we can't get past it. And it creates fences, creates walls. A patient knows they're supposed to go on to the physical therapist, but they can't figure out how to get there. The idea sounds good, but they don't know how to get to the other side. I like to think of permeable boundaries. The idea is that some get through, some don't. And so why is that? Why is it permeable? Do we have to cross over something? Patients experience healthcare often like a maze. There's a lot of things that could be a process for them where they're supposed to see the physical therapist for their hip, they're supposed to see the pharmacist to talk about their drug effects. One drug might be making their care better, one drug might be making their care worse, but nobody talks to each other to figure that out. And it seems like such an easy thing for us to talk and figure out how to get past that. I'm more interested in why there's a boundary. What is it about teamwork, collaboration, or the idea that we can talk to each other and make sense for better health care, but why? What gets in the way of that? There is some kind of boundary, and there's a reason for that. We have different disciplines. I don't know what a physical therapist knows. I need their expertise. I need the physician's expertise. I need the specialist's expertise. I need the pharmacist's expertise. When I practiced in the pediatric bone marrow transplant, we rounded 12 patients all day long with the entire healthcare team. The pharmacist was there all day. The social worker was there all day. The spiritual group were there all day. The child care education specialist was there, the nurse practitioner, the infectious disease folks. I thought, this is great. This is how healthcare is supposed to work. All of the experts in the room talking about the patient all day long with the patient and the family. Brilliant. What I didn't realize is that's not how it always happens. It's not always co-located. So why is there a separation? Is it for controlling communication? Does it enhance it, or does it make it worse? In healthcare, what those missed boundaries cause are gaps in services, right? And we have a lot of studies to show the numbers of mistakes that happen in healthcare. In fact, in some places, sometimes there's more mistakes than benefits. Information is noticed, but it's not acted upon. This happens in primary care. This happens in the hospital. Procedures are ordered, but not received. Consultations are offered, but they don't go. I see so many patients in primary care who say, yeah, they sent me to somebody, but I never went, either because of the costs or because of the gas money, something that had nothing to do with their health care. Care is needed, but it's not provided for all these reasons. I don't believe that anybody gets up in the morning and says, I want to do a bad job. I want to have a terrible work day and I want to make people's lives worse. Most people want to enjoy their work. Most people want to enjoy their health and their wellness, and they don't actually get up to do poor work, but things get in their way. And those miscommunications, those missed gaps are the errors, mistakes, confusion, and increased suffering that happens in patients' lives. And as a nurse, I saw that bedside every single day, to nobody's specific fault, but I really believe that there's system problems and that those are fixable. There are processes that we can understand and we can study to improve. And it's no small matter. In my business, if there is a major mistake, people do die. It can be a problem, so it's worth figuring out. So what does it mean to span? Again, humor me, the idea of spanning is making some kind of connection, maybe a crossing over, the information is being shared. Knowledge management is actually a term that's very comfortably used in the management world. How does one piece of knowledge move into another discipline and we learn from each other so that the product can be better, the service can be better? I think that's important to consider in healthcare as well. There's a connection that happens. It's not just that as a nurse, I suddenly learn how to think and talk like a doctor. We have different kinds of expertise knowledge. And together, we have a synergistic effect of what we can provide for a patient. That's collaboration. It's not just more content, more people in the room, but bringing some kind of connection or some kind of link that really makes information flow in a way. I asked in a room in a retreat in London, we had 3 days with staff from across the entire healthcare system. And I thought I was studying particular people who happened to be good at making connections. And as I was talking to people over the 3 days of the retreat, I realized they were all talking about making connections. They were all talking about spanning and sharing information. So I just did a straw poll and I asked, how many of you, if this is what a boundary and a span is, and how many of you would consider yourselves boundary spanners? Every single person raised their hand in the room. The receptionists, the pharmacists, the administrators, the managers, the clinicians, every single one raised their hand. I didn't ask them what they did or how they did it, but they all saw the potential in their jobs for making connections for better patient care. And that's a system I want to be a part of. I want to be a part of a system where even the receptionist says, you know, this is the piece of information you need. Because you know, when you go into a store, everybody in that store knows something about their products, and they hand you little bits of information that makes it easier for your experience. Why don't we think of that in healthcare? We do, and we should. So when you go back to the idea of crossing boundaries or boundary spanning, there's a ton of literature, it turns out. Not so much in healthcare, but across management. These are the ones in healthcare. And when you talk about boundaries, what kind of boundaries are being spanned? Well, Paula Hyde, in her research, looks at psychiatric inpatient and outpatient clinics. She talks about the personal barriers we set between ourselves to actually protect from intrapsychic stress. it's not easy to work with really stressed patients who are inpatient psychiatric units. So you begin to put up a barrier to protect yourself from any kind of psychic harm, for lack of better words. That's normal. As a professional, you have to do that in certain settings. You just want to get it right. You want the right mix, feeling just close and just far enough to be a good care provider. And that's what she talks about. And these are all studies. These are all empirical studies where they look at the idea of boundary spanning in an empirical way and try to study what it means. Haley looks at the interpersonal aspects of how we know ourselves, how we define our role, and who we connect with in our life. Curry, Finn, and Martin. Graham Curry's doing some really interesting work in England, looking at how different disciplines connect with each other, and he's finding some quite interesting things about flow of power and what he calls hoarding of knowledge. What his research has found is that specialists have a tendency, at least in the systems he studied, in particularly hospital-based systems, that the specialists have all kinds of evidence-based knowledge, but they have a tendency not to share it. It doesn't flow downwards. And so the kind of work they're doing is looking at evidence-based guidelines. Wouldn't it be great if we just knew this kind of patient needs this kind of care and the evidence is perfect to follow this care of management? We're trying to put guidelines like that together, the Cochrane collaboration, NICE guidelines in the UK, so that we can create a management pathway that makes sense based on the evidence. But what they're finding is that evidence doesn't seem to flow between disciplines, even between specialist physicians and generalist physicians. The evidence is there, but it's actually intentionally not being shared. And there's a lot of research being developed in that area over the last 5 to 10 years. Abbott looks at the stressful position of a nurse becoming a nurse practitioner in a place where that has never had one before, and that's a London-based study, that as people change their roles, as their careers develop, they span new boundaries in who they are, how they see themselves, their personal identity. Richter has some studies. He does a quantitative research looking at intergroup and the uncertainty. What he tries to understand is that when people are on the edge of a communication gap, it's very stressful. And that causes, when their job is uncertain, they have more uncertain relationships with others. And he tries to quantify that in his research. Clark looks at different sectors. Thompson looks at organizations. There's a lot of boundary spanning literature around hospital mergers and the stress that comes up as different organizations try to span each other's organizational definitions. And Stern and Green, Stedman, and others have looked at community-based efforts at boundary spanning. What would it mean to have a certain kind of person who works both the justice system and the jails and social work and helps patients move in all those ways? So boundary spanning in the community-based efforts. What I'm interested in is how to improve the quality of how we make those connections. Connections are happening all the time. As professionals, we enjoy our work. We want to make lives better for the people we work with, but how do we improve that, and how do we actually capture it and know how we're going to improve the quality of our work and know what it means? When I think about boundary spanning, I don't think of walls and fences and bridges. I actually like the idea of the cell membrane. It's more organic, and I'm interested in the space in between, because it's not just some wall that you cross. When there's a communication barrier between, say, a nurse and a doctor, there's actually a whole space of interaction that's happening there. Historical turf, professional training, experience that one person has and the other one doesn't, and all that is being communicated emotionally, psychologically, their expertise, their knowledge, and that's what I call the space in between. And what we know, at least in the current models of the cell membrane, is that there are different channels that are conducting. Some are conducting in certain directions and not others, and the more we understand what's happening across the membrane, the more we can begin to train people differently so that they can cross boundaries in a more effective way. Boundary spanning is a term, as far as I could tell from my search through the literature, came out in 1967 from Thompson. And I got back to the real book. Everything's so online now. It was nice to pick up this old book that was well underlined from the graduate library at UNC. And he defined boundary spanning as units that develop in an organization to adapt to increasingly complex structures as needed when there's more interactions happening. If you think of life in a hospital, complex and complicated interactions happen every day. There are millions of decisions happening in every minute in every room in the hospital. And those interactions in a task environment make things even more complex. It can't be all muddled. We really need to try to break that down and understand what's happening. And what Thompson said from the management point of view is that new units or departments develop, boundary spanning departments, new models of how we connect sales to bench-side research have to come up because we need to be able to speak both languages. A lot of the early boundary-spanning literature in the 70s turned out is in the information technology realm and also in the hard sciences, biomedical sciences, because what they look at is that the people selling the science have to understand the science. They have to speak science and they have to speak sales. They have to understand the client, and they have to understand what the product needs are. So the boundary spanners in the early literature were actually not just the units and departments, but actually the adaptations and the people who developed in those spaces in between. And they can communicate back and forth in two different ways, at least two different ways. Such adaptations can invite innovation. So as the organization gets larger, more departments develop, there are more specializations. That's really what was happening in every industry in those days and continues to happen. And that's good. We need more ability to understand the fine expertise in the different specialties. That's happened in medicine as well. Innovation can happen in those spaces. New ideas, new ways of managing knowledge, new ways of managing expertise can happen, but so can bureaucracy. More rules, more controls, more ways of saying you have to do it this way because I have to make sense of this ongoing adaptation. Those are where the benefits and barriers are, and that's where we find ourselves now in trying to make sense of the boundary spanning. A few key articles in the literature go back to the role of the boundary spanner, the individual. Leifer and Delbecq talked in the late 70s about all the different things that boundary spanners are. People who are diplomats, liaisons, they're the glue in the organization who go out and bring new information in, who communicate from the organization out. They tend to be gatekeepers. They tend to be regulators. They tend to be unifiers. Sometimes they're even seen as marginalized because they can actually move across the boundaries in different ways. Tushman, these are classic articles now. Tushman, again in the management literature, said that boundary spanners are individuals and mediators who understand information transfer. They tend to be internal communication stars, but they also face out to the world. And whether we call this PR or sales or service orientation, these are the people who really understand both what we represent as an organization and how to communicate that out to our clients. Williams did a classic study. This is a healthcare study, and he looked at healthcare boundary spanners, and he described boundary spanners as being leaders and reticulists who build trust through collaboration. They're liaisons again. They're able to build sustainable relationships and use negotiation skills because, again, crossing that boundary is an area of stress. My first degree is actually in ancient literatures and folklore, sociology of folklore, and what we talk about in the spaces between, when anything really interesting happens in folklore, it tends to be in an in-between space, twilight or dusk. And those are called liminal spaces. And what happens there is not quite day and not quite night. And so those are the areas that are a little murky. And that's what happens in the boundaries. We're not really sure what's happening. There's one style of selling that's happening and another style of gathering of information that's happening. And it can be a little murky in there. And that creates uncertainty. and it also creates stress. So what we proposed to study as a research team, we went to the National Institutes of Health Research in England, and we wanted to study facilitating knowledge exchange between healthcare sectors, organizations, and professions, looking at boundary spanning in healthcare to see what really happens, and our hope is to connect that to patient outcomes. How does it really impact healthcare quality? We have a great team of an organizational behaviorist, a professor of nursing and mental health, a sociologist in management, a general practitioner, and myself. And we've been at it for almost 3 years now. We're just in the process of finishing up. So I'll talk a little bit more about the research now going forward, but I'll pause just for a second and say, are there any questions or any thoughts? All right. So our research objectives were to look in 2 different things. One was to look at a locally delivered multidisciplinary intervention that was already in play. We didn't set up an intervention. We found one that was already being locally developed, and we sought to evaluate it and see what we can learn from it. Our second objective was to really look at boundary spanning individuals and processes to understand how they function in complex healthcare settings, with the hope that we could actually study it, can it, describe it, and then further healthcare development and professional education by helping to train people in those ways. If you really break down the research questions, we're looking at multidisciplinary teams and how they set goals. We're looking at how they demonstrate their impact on patient care, how knowledge moves across disciplinary boundaries, organizational boundaries, sectoral boundaries, because the knowledge of how we give patient care could be personalized to just that person. My mother only uses this kind of insulin because when she uses that kind of insulin, things don't go well. That's a certain kind of expertise, a certain kind of personalized knowledge, as is the guidelines have just changed for how we prescribe certain medications for this kind of disease. That's also knowledge that has to flow across an organization. So we're looking at all of that. How does boundary spanning activity contribute to improvement? Hopefully the goal is to make things better. And how does it contribute to innovation as well? And when I say innovation, I'm not talking about the invention of brand new technology necessarily, but how do we look at new adaptable ways of providing care that could be innovations in the local system? However, it's not a nice, neat laboratory. There's some fantastic literature about collaboration in surgical teams, named people in named spaces around certain kinds of surgeries. It's a nice fixed space. Primary care is messier than that. It's asynchronous. Everybody is receiving care in different ways across space and time, different kinds of providers. And on top of that, the United Kingdom has a slightly different healthcare system than we do in the States. And it tends to change when the government changes. So every few years there's an election, a new party comes in, and the Department of Health, which is their overseeing body for healthcare, some of that leadership changes. And then some new policy initiatives come out, and that changes. And so what I find there, unlike my experience in teaching nurses and functioning in primary care myself, they talk about change all the time. Reform, we've seen it before. I remember that last initiative. I met more nurses in the UK who could tell me what lean meant, or what organizational change they were doing, or what the latest term is for change. And depending on who you talk to, they talk about cycles of change. That was 10 years ago. It happens every 10 years. Depending on how fast their industry is moving, the cycles are tighter. In general practice, it seemed to be about every 10 to 15 years. In the hospital, it seemed to be every couple of years. And as new ideas came out, they got really excited. They rebranded everything. They got new cards. They had new badges with new visions and missions on them. And your average staff could talk about mission and vision and change. But when you ask them, how's your job look? It's the same thing. I don't know, they call that innovation this year, but last year it was something else. So they talk about moving the chairs on the Titanic all the time. My experience in primary care in North Carolina was the opposite. Change. How could we change anything It's too hard to do change, but some of the same fixed problems. What's happening there in the UK right now, obviously, is not just the usual changing dynamic, but they also are facing major price pressure, economic pressures. £1 billion were transferred to social care for a different way of spending. Providers were facing price drops, so they're not getting paid as much for their services. And there was the thought that $20 billion in efficiency savings needed to be achieved tomorrow. And we're familiar with these kinds of concerns with cost. This is the language out of some of the political bills. The hope was that efficiency would be achieved through quality, innovation, productivity, and prevention. No one could disagree with that. How you actually do it is a whole other issue. Think tanks, King's Fund is one of the large ones, is talking about integration. We need to integrate services. One of the things we know from the American system, and I can show you statistics later on that, duplication of services is one of our major problems. Same tests getting ordered over and over again. Comparative statistics internationally show that we order more tests again and again than any other country in the industrialized world, and we actually have less information available at the point of care in the US than in other countries. So those are inefficiencies. How do we make that better? I can't take care of a patient and talk to them about their test results if I don't see the test results. So every one of those problems becomes not just a problem for the patient and our interaction, but of course costs. People always ask me, so I thought I'd throw in just a couple of quick slides about the national healthcare system in the US, in the UK. The National Health Service was founded in 1948, came straight out of World War II, Blitzkrieg, bombed the living daylights out of London. The whole city was falling apart, and the call came forward to do something for our own. And the NHS was born in 1948 by Nye Bevan. People talk about him, they know him, he was a Labour MP, but people were putting pennies in cups to form the National Health Service. It's a form of pride, it's something that's very close to people's hearts, and the thought at the time was, we'll just prevent problems before they start. Of course, that's long before screening MRIs and CTs came along, before we had a lot of screening tests, and before people lived 100 years. So the cost of prevention has gone up dramatically. Basic services are available by design to all residents, not workers, not citizens. If you live there, you get services. That's how it was defined. Anybody in London can tell you if they, in England, can tell you if you ask, what are the core values and principles of the NHS? That it meets the needs of everybody, that it's free at the point of delivery, that it's based on clinical need and not ability to pay. I had a bad cough, was wheezing about 6 months ago. I needed an inhaler. I walked into the GP practice 1 block away. I was seen immediately. They didn't ask for my card. They asked if I had a local address. I said I did. They saw me in 10 minutes. I walked across the street to the pharmacy. I was home within 35 minutes with an inhaler, an antibiotic, and some Tylenol wash for my throat. That's how it's designed. They don't send a bill, but what that means is they actually don't know how much it costs, necessarily. The goal in primary care is to take care comprehensively at a basic level of everybody who lives in your neighborhood. So when I talk to the nurses there about how my patients get care, well, when you come out of the hospital, you get the ER bill, you get the anesthesiologist bill, you get the bill from the liver doc and the kidney doc and then the pharmacist, and then you get your medications. That doesn't happen there. We have a fantastic system in the US for pricing what we give. We know how much it costs, and we track that. They don't. They figure you go into the hospital, you get what you need. So they're not as able to keep track of services, but they are able to keep track of making sure that everybody is there. Of course, there are lots of minuses and pluses to this kind of thing. I will say that public health there means taking care of society. I think of public health as more epidemiological and certain kinds of health promotional aspects. Public health implies a social good there in the way that there is a responsibility of local governments and general practices to take care of the public as a whole, and that's what public health means. In the current system, hospitals are semi-autonomous. They're governed by public and local trusts. Some of that's changing up a little bit. 89% of medications are provided free of charge on a limited list. Anything beyond that may cost more. Women, children, and elderly all get their medications for free. Everybody else pays, I think it's £8.10 now for all your medications. So the kind of thing that I do with my patients in North Carolina, where I try to figure out what costs more, their gas bill or their heart medication, those aren't conversations they have. They don't get to choose from a bunch of different medications. They choose what's on the formulary. Private health does exist there. People can choose to get a policy. They pay extra for it. I tried to find average numbers and I couldn't, but I've talked to friends of mine. They pay about £1,500 a month for a family of 5 for comprehensive health care on BUPA, which is Blue Cross Blue Shield, or a version of it, which is actually a lot less than we would pay for a family. They do not cover medical emergencies. That's covered through the public health system, chronic illnesses, or transplants. So private health only covers so much. It does offer you specialists, access to specialists, and private rooms. And people who work with high net worth employers are more likely to have private health. It's about 4% of care expenditures. Anybody can have it, but many don't choose to purchase it. Workforce is huge. 1.43 million workers, and of that, a good portion are professionally qualified clinical staff. There are a lot of support staff. If you look at the recent numbers, actually they've gone up by about a half to a third, a quarter to a third over the last 10 years, and it's hard to say why the numbers are increasing, whether it's for services or certain kind of bureaucracies. Primary care in England, you can decide. You can actually see who's in charge of what, where the responsibility goes. What I think is interesting, when I ask my nurse and nurse practitioner students to draw the healthcare system in the US, you can't. We don't think of it as a system. You know, well, here's where you go. Where do you go for primary care? Well, you could go here and you could go there. You could go to a free clinic. I asked nurses in London, are there any free clinics? And they said, why would you need a free clinic? Well, where do people who don't have health care go? Well, we don't have people who don't have health care. Why would you need a clinic that does that? So just different ways of conceiving where and how patients access care. The model here is that patients access through primary care. The generalist physician is the person who is supposed to guide that care. The trust that the GPs are a part of then control the budget, which is about 80% of the overall budget. There's almost 40,000 general practitioners across England, and they control about 85 billion pounds in funds and spend roughly about £1,600 per person providing comprehensive care that is free at the point of service. So that's the model. What happened in the middle of our grant application is that a new election happened and a new white paper came out. And in that white paper, it was decided that managers shouldn't be making decisions about healthcare. General practitioners should be making decisions about how the money gets spent. So the vision was put out that patients should be at the heart of everything. You hear the language that's not atypical. It's hard to disagree with, but of course how it really happens is the political reality. Continuous improvement is important. Clinicians need to be able to adapt and change to what is needed, and that quality cannot be delivered through top-down targets. We have to let generalists control the budget and the adaptations in the local area. That's what makes most sense. That's what the policy said. What happened? Major uproar. Should we have it? Shouldn't we have it? The Nursing Association is against it. The Generalist Association is against it. And everyone started adapting immediately, even though it hasn't officially been voted on yet. So the policy wasn't even put into play, but of course everyone started fighting for funds right away, and it's causing a major amount of distress. We'll see where it goes. Policy changes happen, political realities happen. It's hard to have an opinion one way or the other, but this fellow here, Andrew Lansley, is a conservative MP. He's the face and vision behind this white paper, and there's all kinds of interesting raps and YouTubes against what kind of a evil person he is. It's hard to say if he'll come down in history as making a positive change or a negative change. We'll see. In the midst of that, we're trying to study healthcare and how to make it better. No way we can fix the context. We cannot say, all of you stay still. We just want to see what makes things better in just this one way. There's no randomized control study that could really happen in this environment. We engaged in an in-depth longitudinal study during the period 2009 to 2012 using observation, interviews, focus groups, surveys, diaries, as well as secondary analysis of indicators of the data that they already collect at the national and local level. That's really been the work that I've been involved in. It's a nested case study in Northwest London. This is one of the most diverse populations across all of England, and it's also one of the most deprived. They call it the deprivation indices. We can look at, here we look at school lunches. There they look at level of chronic diseases as well as poverty indices, and this was a really challenged environment. What the intervention was something locally developed by a GP who tried to bring in a learning cycle across different aspects of this local area, and the stakeholders themselves said these are our biggest issues. Paul Williams in his study of boundary spanners called them wicked problems, the societal issues that aren't easy to solve, that impact healthcare. Dementia was a big issue. Stakeholders, local volunteer groups, local social groups, local patients and carers said dementia, child and family health services, diabetes, and depression and anxiety are a major concern. Fix this and we'll feel better. These are defined as they define them. So BME backgrounds is a common term there. They call it Black and ethnic minority backgrounds. Really high Asian population. In this part of town, there are up to 12 different Asian dialects alone that are happening there. So care is complicated by language barriers, as well as immigrant status and sometimes people seeking asylum and the complications that happens along there. There had been some really nasty cases of child abuse that hadn't been detected by pediatricians and social workers, so Child and Family Services was a hot topic as well. So they presented us with these topics and said, help us evaluate. So that's what I did. They imagined vision. They got together and had brainstorming and enthusiastic group meetings to try to figure out what do we have to do, look how much there is. They're very upset about government targets. They're very upset about budgets. They're getting a lot of media, bad press for bad care. What do we do? How do we fix that? How do we improve that? And so this is how they envisioned what they wanted to do, is to improve patient care through better leadership and then figure out how to take that forward. They embarked on what they called annual learning cycle and practicing general practitioner who started to walk the local groups through these learning cycles where they would train, appraise, innovate, and continue to see what was happening. And my job was to observe all of this as it happened through now about 2.5 cycles. I asked them to begin to collect their own data, because collecting data isn't what clinicians, we collect data, but we don't always assess it and look for patterns to fix. So I said, well, you're taking names to invite people. Why don't you actually look at how they break down? Here's how they broke down in the 2010 year. They really crossed a pretty wide area: local government representatives, senior management, patient voluntary groups, general practice, GPs, nurses, school nurses. Pretty wide engagement. Not a ton of attendees, but for a local town, it was pretty well attended and continued on. What I proposed to do was to look at what we came to define as boundary span interfaces, primary care in all these 4 areas, so that the mental health aspect was looking at the depression and anxiety aspect, the social care aspect was looking at dementia, diabetes was the hospital specialist area. So 4 teams were defined, 4 leaders were defined. They met on a regular basis to try to define what are our problems, how do we fix them, how do we study what we did, and how do we put that into place. What I have found, I've put here as emerging themes. I'm still deep in the analysis of the data. There's still a lot of quantitative and qualitative crunching that has to happen, but there are about almost 100 hours of interviews, about 200 to 300 hours of observations, as well as the surveys and the diaries and the secondary data sets. I think we have 40,000 data points in the data sets that still have to be put into context with this. So, diabetes. The issue with diabetes, the team decided that they wanted to create a multidisciplinary outpatient team to provide diabetes care in the community. Sounds like a great idea. It's been done before. There are models of outpatient primary care diabetes teams. They have diabetic specialist nurses. They could put them out in the community. Patients could practically walk up to the door, get good comprehensive care. Only it didn't happen. It didn't happen for 2 years. What happened was that they found that the power differentials existed. The diabetic specialist nurses were housed at the hospital and they didn't want to leave. The specialist had data on all the patients but didn't want to share it. The meetings would start but they wouldn't finish, and so the clinic got shelved. So they moved into other kinds of things. Well, what I can report now is that the outpatient diabetes clinic staffed by a diabetes specialist nurse opened last week. Now, the goal was to open it 3 years ago, but they did open it. And within that process, I think there are a lot of lessons, some of which were what we know from Furley and Graham Curry's research, is that there are power differentials and there is a knowledge hoarding that begins to happen. Some of that is because of funding, some of that is because of asymmetrical flows of information. Lists and names of patients weren't being shared. Decision-making was being shifted. But certainly, we have enough data now to say that specialty care doesn't necessarily improve chronic disease. And high costs are definitely linked to acute and unplanned services. We have the data to show that. What this team needed to overcome was systematic and structural problems, cultural barriers to how we've always done things, the comfort level of the practitioners to actually step out of their usual level of comfort, to try a new model to see if it would work, and that's been happening. Slow progress, but if we weren't watching longitudinally, I would have called this a failure. But it actually has turned out to be a great success. Everybody wanted better diabetes care. They just didn't know what to let go of and what to share. Multidisciplinary efforts, what I've seen happening here is everybody on that team needed personal mentorship. And sometimes they actually came to me as the researcher for that. You've been watching. What did you see? Did you see what I saw in that meeting? How is that working? The people who were trying to lead change didn't always have the authority to lead change, and they needed encouragement to face the uncertainties of crossing that barrier. And in the meantime, by the way, 70% of staff were fired because of cost problems. So internally, I was going to more leaving parties than I was connecting parties early on in the process. But some of the same people have continued, some of the same goals, certainly for good care, still exist. And these are just some of the ways that we've been using surveys across the primary care clinician groups to look at some of the changes, their level of confidence, their working relationships, their ability to seek out external organizations. Those are some of the kinds of metrics that we're looking to see if that'll give us some fruitful measures. Primary care and social care had a different level of problems. Secondary care and dementia, inpatient care and outpatient approaches had a lot of ideas for what they wanted to do. The leader of the team lost her position. They devolved inpatient to a different setting. They hired a nurse and stepped up his skill level to make more outreach, but nothing seemed to make any traction. And in the middle of it, as the new policy initiatives came out, dementia wasn't on the list. So when dementia fell off the policy initiative list, it also lost some funding, and this one really struggled to make any kind of options. What I did see when I sat in some of the stakeholder meetings, I saw physical therapists show up time and time again to say, I am seeing dementia in my patients when I visit them at home. I showed up here so you could teach me how to recognize it and refer appropriately. And nobody listened. They were right there, they were eager, and they continued to show up. They were invited. And every time they said, I have a way that I can recognize dementia and send them back so they can get appropriately assessed, it never got picked up. And those are those missed opportunities. They're there. There's an eagerness to learn, but it has to be built and built in. I also interviewed a few people who said, oh, you know who you need to talk to? You need to talk to so-and-so. They're great. They go above and beyond. They just do everything. When there's a problem with a patient, they call and they call and they call. So I said, well, what happened to that person? Well, I told him to stop working so hard. We don't get paid to do that. So the idea that good quality care happens in a above and beyond kind of way is a bit of a theme, unfortunately, because what happened is as costs started going down and staffing started going down, they'd start saying, it's not worth it. Or their boss would say, you know what, stop going to those meetings. I don't pay you to go to those meetings. You have care you need to provide. I also talked to it's a bit of an aside, but I talked to one of the cognitive behavioral therapists from the mental health team who learned how to assess for dementia, do a quick assessment in one of these meetings. And she was working in therapy with a patient for a couple of weeks, and the patient started talking about forgetfulness. And she said, you know, I know what this is. This is probably dementia. I need to send her on for a good referral and a good assessment. The chart got lost 4 times. She had to call through 8 different steps to get that patient to the right assessment as a mental health professional in a different part of the system. But she knew how to do it because she had attended these things. She went above and beyond. She got in trouble that week because she didn't meet her caseload numbers. So there are ways that the bureaucracy can get in the way of letting people know how to find creative solutions.
So I have a question. So in this case, you have many sort of systemic factors like the bureaucracy, like low rewards, things that might explain motivation there. But similar to the diabetes case, it seemed like with the knowledge hoarding, I was trying to understand that where, because it's not that it's that surprising, but is that a motivational issue or is it an agency issue in terms of capabilities, or you know what can explain after you point out to people that if you retain this information and don't share this patient list, guess what? People can die.
Right.
Does anything change after that?
It's not so direct. It tends to, from my understanding, it's more on a psychological level. I do a better job with these patients than you will. So I'm not going to let them go, and I'm making a patient care decision based on that. So the motivation is my knowledge is expert level, and I'm not really willing to let go of this patient to somebody else who may do less of good work at it. So the evidence that we need to collect is where does the benefit come in? If it really is going to improve patient care, we need to find different ways to collect that kind of information to say specialists do, of course, fantastic work in the right setting at the right place, as do generalists. We need to find the right evidence to learn how we appropriately share. Got it. We did a survey. This is just an example. We did an online survey through SurveyMonkey directly out. And again, we asked slightly different questions throughout the survey, including ease of referrals. Again, looking for how these boundaries are getting crossed. Is it a referral issue? Is it an information issue? Is it a knowledge of local services issue? Children and Family Services, this group was so disparate, they weren't quite sure what their goals were. I was trying to track goals and ability to accomplish tasks. It was very difficult to do that in this particular group. It's such an asynchronous area, whether or not it's safety issues for children, involving school nurses, involving social workers, involving physical therapists and all the different ages. And so this tended to be more personality dominated. Somebody who cared a lot made an effort, somebody who knew people pulled the strings of personality to make things happen. Those who didn't. And so of course you don't have a real replicatable process in here, unfortunately. A lot of opportunities for learning horizontally across the healthcare system, but the top-down measures just didn't get translated very well. We did look at understanding working relationships across different types of healthcare providers in the external world with primary care. And then we looked at anxiety and depression, which actually turned out to be one of the best examples of what was effective. The mental health care team had a top-down initiative from the government to increase cognitive behavioral therapy in the outpatient community. The problem was many Asian communities don't recognize the word depression. The screening tools aren't translated in their languages, but they have huge rates of homicide, crime, suicide, things that might be related to depression, anxiety that were being unrecognized and untreated. They decided that their effort was going to go door to door. They went to where the general practices were and said, this is the service we offer. We will provide cognitive behavioral therapy to your patients. This is how you refer to us. This is how you use us. And word of mouth spread until the general practitioners were banging down the doors saying, how come I don't have a cognitive behavioral therapist in my practice? Because I have all these complicated cases and I want you to take them. So their marketing efforts worked. It was word to word. They increased their referral rates by 300%. Within the first 6 months, and then they were a matter of trying to figure out capacity issues. Do we have enough nurse therapists? Can we train more? Can we do more kinds of advertisements? They started translating the PHQ-9 and other sorts of screening tools into other languages, and it's been very effective. They've turned themselves into a social enterprise and are in the process of adapting to a new community-based effort in that way. And so some other ways of looking at how they could share information. So we're still diving into making the comparisons across time and different teams. So emerging themes, local adaptation really is the whole point. Significant personal development happened. I talked to people whose lives were changed on a daily basis. This was so exciting. I'm thinking differently. I'm seeing new people. But if their bosses didn't support it, they'd stop going. If they didn't have a process in place, they couldn't carry it through. The enthusiasm wasn't enough. They needed to be taught how to collect evidence. They started to look at me as an embedded researcher to teach them how to evidence their own care, and I continue to be involved with them. The mentoring of the leaders was really necessary, but it had to be ongoing. It couldn't just be every 3 months. It's a time-intensive process, at least as this model was working. Problem solving and knowledge contribution in the evaluation sense are really what we're balancing. I won't spend a lot of time talking about that, but I will say that it's not about the macro level policies. This is what my read of the literature is saying. This is what my read of the local decision making is happening. At the micro level, relationships are happening every day, and some people are empowered to make changes and continue to adapt, and it could be different in this side of town than that side of town. There are geographical boundaries, there are cultural boundaries, there are social boundaries, and at the micro level is where the research is needed. We need to understand what empowers change in a sustainable way, in a measurable way that happens when we're really doing local adaptation. The system we inherit is the system we inherit. It has its flaws, but within that there should be processes we can define, and that's really where improvement science is headed, at least as far as healthcare is concerned. So I think I'll wrap up there and take questions. I think I've gone a little long. So any questions? Yeah.
We have a talking stick since we're recording this. So
Oh.
I was was really interested. It's a wonderful, rich presentation, and I'm not familiar with all this literature, but it seemed like when you think about the elementary concepts that you try to outline, that the boundaries are presented more in space, and yet many of the issues that you indicate that were important happen in time. And so I was wondering, in a more abstract way, where does time and space intersect in boundary spanning?
That's a great question. My experience as an ethnographic researcher were that when I was sitting in a stakeholder meeting with 50, 60, 100 people, little conversations were happening all the time. And for me, that was spatial. I could see certain parts of the room and certain parts of the conversation that were popping up. But they wouldn't have been there if they hadn't been there in time in the same space. So shared learning space is, for me, an educational concept. The opportunity to cross paths with somebody you've never crossed paths before and have that moment where you say, I had no idea social workers did that. I didn't know that physical therapists knew anything about dementia. Those moments were, in my mind, space and time crossing, where a new connection happened. And the following week is when someone would pick up the phone and say, you know, we had that conversation. I didn't know physical therapy was available in town in this way. Let me refer a patient to you. So something happened, some kind of magic happened in those shared learning spaces that I could only have studied longitudinally over time by going back and hearing the stories again and again. I'm using serial diaries, so I'm also asking people to send me diaries every 2 weeks, and those have had some of the richest data, actually, because it's not just what I saw today in a snapshot, it's the movie over time. Yeah. In the back. Oh, it's recording, so it's not actually amplifying, but it's recording. You know, I hear that question all the time, and I will not profess to say what the answer is. I will say that anticipating that question, which is a version of, well, so how are we doing in the U.S.? And you've seen these before, probably, as far as costs. We are spending at least 3 times more than almost every other industrialized nation. We are one of the only industrialized countries that actually does not offer universal health care. And I'm not talking about nationalized and who pays for it, but universal health care as a social expectation. We are one of the only countries that does not have that in place. And we're paying a whole lot more for providing a lot less to our clients. But that's kind of, you know, you can play with the numbers a little bit. The Commonwealth Fund is one of the most interesting players on the field. It's international, comparative, quantitative study. Dr. Foster's is doing the same thing with hospitals in the UK and now in the US. Leapfrog Group is trying to do some comparative systems. So while I can't say what the best system is, it's complex, it's complicated, and we have some moving parts that are working really, really well in this country. We also have some parts that are really failing miserably that other people have solved. What I would like to see is more sharing of experiences, data, and data collection to learn the best from what's being done. In one part of town, one kind of model may work perfectly, but on the other side of town, it may not work at all. And we need to learn how to adapt on a regular basis. If you look at these numbers, red is worse and green is better. Germany and the Netherlands have been vying for top candidates over the last couple of years. Germany was on top last year. The shifts change. There are different parts of the system where we seem to figure it out. This is across many different hospital systems and primary care systems. If the cost is across the bottom. If you look at effective care, Canada is 7, Germany is 6, UK is number 1 at effective care. US is number 6. Patient-centered care, UK is trying, but not quite there, 7 for patient-centered care. So their latest policy call is to put patients at the center, increase patient choice. Coordinated care, which is really what I'm talking about, is closing the gaps in service and coordinating care. UK is doing reasonably well at 3, we're at 6 for that. That's what I experience with my patients. I have to make how many calls to get them into the kind of care that they need. That's inefficient, it's ineffective, it's bad care, it's a waste of my time as a clinician, and it doesn't really work. There are other systems that seem to have done a better job of that. We should be learning from them. As they can learn from our technological advances, we do a fantastic job of that in this country, but do we need to screen every single patient with an MRI? Probably not. So learning what's appropriate for which population at what time is really what I mean when I say local adaptation. Right care, right time, right patient, all the time. Level of expertise is hard to gauge. There are a lot of statistics. When you look at the Commonwealth Fund, they bear out how many tests have to be ordered before somebody gets the right diagnosis. That might be one way to look at this. If you look at, which one of these is, I think effective and safe care is built into the measures of expertise. And the double testing and triple testing come into these measures. So there are systems that have figured that out. They're doing all right here, but they still have patients falling through the cracks. Again, it's really hard to give it one flat answer. In fact, I'm coming to the point in my career where I don't want to give a flat answer anymore. It's too complicated of a system and it has too many moving parts to say all good, all bad. Learn the lessons of what's most effective, learn how to apply that to similar systems and replicate it, and that's the best we have. So it's a bit of a non-answer and a bit of a politician's answer, but I think there's some truth in adaptation. Yeah.
So a related question is, have you determined that there's variability from year to year?
Mm-hmm.
When I worked with the King's Fund, there were over 100 reports between 1876 and about 100 years later on how you changed the London teaching hospitals, the specialty hospitals. So there's this sense that in the UK, as you said, that they're always changing.
Mm-hmm.
My question to you is, what have you learned about when any of those changes within one system, not across systems, have been effective at improving health outcomes?
Again, it's a little bit of a non-answer, but my understanding of the literature and experiencing studying boundary spanning is there's something to be said for what's called uncertainty. In the space between is a lot of uncertainty and ambiguity, and that is role strain and job stress in the management literature. People burn out faster when they're not sure and clear about what they're supposed to be doing. So I think that the mission for a good teaching environment is really teaching people to adapt to and cope with uncertainty. That's when they do well as patients, that's when they do well as learners, that's when they do well as clinicians. So it's not that they have to control it, it's not that they have to understand it, it's not that we can even improve or increase the amount of content we give them. We have to teach them how to adapt to uncertainty and respond appropriately. And that's a dynamic in how we understand learning. So learning theory is a major part of the hypothesis we're working with. What is a learning organization? It has to see its problems and adapt to them. It can't cover them up, it can't ignore them. It has to gather the data, see the problem, and adapt. So managing uncertainty, I think, is going to be the key to how we redefine our educational systems and integrate them with giving care.
So I think we'll move the discussion next door where we have beer and wine and cheese and veggie munchies. For those of you who are watching this later, sorry, we'll have an extra beer for you. For those who want to participate, we have some threads of discussion on the FAB website. That's phab.us, and we'd welcome you to join in that discussion. So thanks very much.
Thank you very much. I really appreciate it.